Thank you for joining me for this talk on cardiac amyloidosis evaluation in nuclear medicine. My name is Paige Bennett, and I'm a board-certified nuclear medicine physician and academic professor in the United States. I'm also the creator of Nuclear Radiology Instagram, a social media-based educational forum about nuclear medicine. Amyloidosis is caused by abnormally folded proteins in the body that build up in various tissues such as kidneys, liver, and spleen. When these proteins congregate in the heart, it's called cardiac amyloidosis. This buildup of abnormal proteins in the heart muscle leads to thickened heart walls with firm and rubbery consistencies. These heart walls do not relax properly, leading to heart failure due to diastolic dysfunction. Patient symptoms include fatigue, dyspnea, and edema. Although there are about 30 types of amyloid proteins that can build up in the body, there are two types that predominate in the heart: immunoglobulin light chain and transthyretin amyloidosis. When cardiac amyloidosis is suspected, evaluation focuses on distinguishing between these two types, AL and ATTR amyloidosis, since they have different etiologies, management, and long-term outcomes. For a long time, we've known that visceral organ uptake can show up as an incidental finding on bone scan. This has led to research on 3 bone scan radiotracers that can diagnose the presence of transthyretin cardiac amyloidosis. They are Tec99m PYP, DPD, and HMDP, all bone scan tracers. Which ones are used depends on geographic location. For example, PYP is approved for use in the United States, and DPD and HMDP are used in Europe. With immunoglobulin light chain amyloidosis, aggregated immunoglobulins are deposited in the heart muscle. Diagnosis consists of lab work as well as amyloid deposits evident on abdominal fat biopsy. As light chain amyloidosis is a plasma cell disorder similar to multiple myeloma, treatment consists of chemotherapy and bone marrow transplant. Now, transthyretin cardiac amyloidosis can be genetic or aging related. It is most common in men over 70, and it is estimated that 3 to 4% of U.S. African Americans have inherited the mutation of the transthyretin gene. Normal transthyretin proteins transport vitamin A and the hormone thyroxine. Misfolded proteins aggregate in the heart, and diagnosis can be made using the nuclear medicine amyloidosis scan instead of an invasive myocardial biopsy. Treatment includes newer disease-modifying agents to slow the process and up to and including cardiac transplantation. Next, let's talk about the cardiac amyloidosis scan and its protocol. There's no particular patient preparation for the scan. The dose is between 10 and 20 millicuries. The dose to scan time is 1 hour, and we do both planar and 3D imaging with SPECT or SPECT-CT, and you have an additional optional 3-hour image as well. Planar images are acquired over the chest in anterior lateral and left anterior oblique images, followed by SPECT or SPECT-CT images. Let's review first what a negative study looks like. On these images, you can see the ribs and the sternum with no uptake in the expected location of the heart on the anterior, the lateral, or the LAO images. On the SPECT and SPECT-CT, you can see that there is no uptake in the myocardium. You just have uptake in the blood pool, suggesting no myocardial uptake. And then on the region of interest analysis, you have two regions of interest showing a region over the expected location of the heart and over the contralateral chest. Where the regions of interest are located can be very important, and I will show you more cases about that later, but in general, you draw one region of interest over the cardiac region, and then you mirror it over the contralateral chest, hoping to avoid the sternum and to include the same amount of ribs. Total and absolute mean counts are obtained for the region of interest, and then the ratio is calculated from these counts. Here you can see a positive scan for transthyretin amyloidosis, and the ratio is 1.59. Here you can see a negative scan for transthyretin amyloidosis, and the ratio is less than 1%. Next, let's talk about interpretation of cardiac amyloidosis scans. And in general, I follow the American Society of Nuclear Cardiology guidelines for interpreting these scans. One main part of the interpretation is the ratio that we've been discussing. For transthyretin positive amyloidosis, the heart to contralateral ratio is 1.5 or higher. For amyloid light chain or no signs of transthyretin amyloidosis, the heart to contralateral ratio is less than 1. An indeterminate range is between the two at 1 to 1.49. In addition, semi-quantitative visual grading comparing the myocardium uptake to adjacent rib uptake is used. Grade 0 or 1 shows no uptake or uptake less than rib uptake in the myocardium. Grade 2 or 3 shows uptake equal to rib uptake or greater than rib uptake, and grade 2 or 3 would be diagnostic of transthyretin cardiac amyloidosis. Here you can see from the American Society of Nuclear Cardiology guide examples of the 3 grades. With no uptake, very low uptake which would be not diagnostic of transthyretin cardiac amyloidosis, and then uptake which is similar to ribs or greater to ribs, which would be indicative of transthyretin cardiac amyloidosis. So for example, on this case, you can see the patient has had a median sternotomy, looks like on the bone scan portion, but there's no uptake in the myocardium, and all uptake is in the blood pool, and the uptake is less than ribs, so this would be a grade 0 or grade 1, which is not indicative of transthyretin cardiac amyloidosis. And contrast that one with this SPECT scan, where you see very little rib uptake and really high myocardial uptake in the left and right ventricle. You can see that on laterals and obliques. And when you get to the SPECT CT, you can see all the uptake is in the myocardium, in the left ventricle and the right ventricle. And then the ratio is pretty high at 1.7. This case is an example of when you might want to get a 3-hour image. You can see that there is a lot of soft tissue uptake on this scan. You're not really seeing bones, you're not seeing heart, all you're seeing is a bunch of tracer in the soft tissue, and you can't be sure that your region of interest analysis is correct because the biodistribution is altered for 1 hour. So in this patient, these were the 1-hour images, and these were the 3-hour images. And you can see here that now you can see some rib uptake. You don't see any myocardial uptake, and the ratio can be performed more confidently. Next, let's look at some cases. This case shows no specific uptake in the heart, looking like it's a grade 0 or grade 1, but you can see a haziness between the ribs on all the planar images. And you can see here that it's due to the pleural effusions, which is a secondary sign of heart failure, which is a common reason why patients are worked up for cardiac amyloidosis. This is a case that was indeterminate for transthyretin cardiac amyloidosis. You can see the grade is maybe grade 1 or 2, similar to the ribs, but the ratio didn't turn out to be high enough. The ratio was 1.25, so it wasn't totally diagnosis of transthyretin cardiac amyloidosis. This is a case of markedly positive uptake, showing grade 3 uptake greater than the ribs. Even the ribs are very hard to see. The ratio of the heart to contralateral lung is 1.6, which is very high. On this SPECT, you can see you're confirmed that you see it in the left ventricle and a little bit in the right ventricle. So this is diagnostic of transthyretin cardiac amyloidosis. This is a case of transthyretin cardiac amyloidosis where the right ventricle is involved as well, and you can see how this might have implications for our region of interest analysis, and I'll show you a few cases of that in the future. But in general, you don't want your region of interest to go over the right ventricle, and so we had to move it out here to get a more accurate region of interest. So let's now review some pointers on how we can get the best possible study of cardiac amyloidosis. First, positioning is important. You want the patient to be straight on the scanner, and you want the sternum in the center, and in general you want both of the ribs to look like they are equal, and then you'll know the patient is straight on the scanner. You can see in this instance the sternum appears to be off-center. The ribs measure much longer on the right side than on the left side, and you're not getting a great straight view of the heart, and you're at risk of having the right ventricle included in your contralateral region of interest. So the ribs should be the same width. So let's go over all the pearls for region of interest placement. So with ATTR negative scans, it can be really hard to see the heart. And with ATTR positive scans, you want to make sure the heart is in the heart region of interest and that the contralateral region of interest doesn't contain the right ventricle. Avoid drawing the region of interest over the sternum. Make sure you have similar amounts of ribs in both regions of interest, and avoid any liver or kidney uptake if tracer is evident there. In general, we try to draw the regions of interest at the same horizontal level, although they can be apart a little bit to avoid the right ventricle. Here you can see cases of right ventricular uptake where the right ventricle was included in the region of interest. This is a good size for the region of interest in general. These regions of interest look a little too big, and also this one on the right includes the right ventricle, so that's going to mess up your ratio. And then the last region of interest, they look like they're on the same horizontal line. They're a good size and probably don't include the right ventricle, so that one looks good. On this region of interest analysis, you can see that the regions of interest, the bottom of this one goes a little bit below the horizontal line, so it'd be probably good to move it up a little bit, and then you would be getting more of an exact heart to contralateral side ratio and not include the liver. This is a case showing that the patient is turned, and you see the sternum, you see lots of ribs over here, very few ribs over here, and the region of interest over the heart is actually over the breast tissue. And so when you reposition the patient, you can see the sternum in the center. The region of interest can be nicely over the heart and over the contralateral chest. So make sure the sternum is in the center so that you don't get regions of interest over soft tissue that's outside the chest. And this is an example of the same patient where we did 3 region of interest analysis, and you can see on the first one that the region of interest was overlapping the right ventricle, and the ratio we got was 1.29, which is indeterminate. Although by grade this looks like it'd be pretty high grade because there's no rib uptake, so this looks like a grade 2 or 3. So that ratio didn't make much sense. Then we drew the region of interest again, and still got a little bit of the right ventricle in, got another 1.29. So on the third try, we moved the region of interest over the contralateral chest. We felt there wasn't a lot of rib uptake anyway, and so that moving it over a little bit would not change much for the ribs. And our ultimate ratio, which we felt was the most correct, was 1.62, which correlated well with our visual grade analysis and was positive for transthyretin and cardiac amyloidosis. So remember your protocol pearls. If it's difficult to see bones due to generalized high soft tissue uptake on early images, consider 3-hour images, especially in renal patients. And then if it's difficult to see the bones on early images, ask yourself, is it because the heart is taking up all the tracer? If the heart is taking up most of the tracer, you just may have a grade 3 uptake, and a 3-hour image isn't actually necessary. And remember our example of the renal patient where 1-hour imaging had a lot of soft tissue uptake, but 3-hour imaging was more diagnostic, showing ribs and no cardiac uptake. And remember to always perform the SPECT or SPECT-CT to show uptake in the myocardium. Here you see it in the left ventricle and the right ventricle versus the blood pool. You can see the photopenic myocardium here on the left. And then you also want to make sure that you're not seeing it in another structure such as a tumor or a hiatal hernia with some free protectanate. You're going to want to make sure that you can see the heart on a 3D view. So I hope you agree that today patients benefit from transthyretin and cardiac amyloid being diagnosed on a nuclear medicine scan instead of an endomyocardial biopsy. Remember, a negative scan can still be light chain amyloidosis depending on lab work and an abdominal fat biopsy. Also, for patients with an indeterminate scan, further workup is often required to determine the etiology. Unfortunately, at this time, these nuclear medicine scans can't monitor response to therapy, and imaging for response to therapy is still in the research phase. Thank you very much for joining me.